And I could tell you that 9 times out of 10, what really happens is, either they come at 3 months and we get them in and do their body composition, and we see that yes, they did lose weight, but they lost a tremendous amount of.
Welcome to Beyond the Scale, where we delve into the transformative stories of business owners who have harnessed the power of body composition to elevate not only their own enterprises, but also the lives of their customers and patients. I'm your host, Bradley from InBody. Today we're going beyond the numbers on the scale to explore the profound impact that body composition can have on medical spas. From deep insights into how to identify muscle, fat, and water imbalances to unique ways that body composition can be used to enhance patient outcomes, upsell more memberships, and increase patient retention. You have an InBody or are thinking about getting one, and you work in a med spa or provide medical aesthetic services, you don't want to miss this conversation. So without further ado, let's dive deep into the intersection of healthcare and body composition right here on Beyond the Scale. Today, my guest is Dr. Pompeyo Chavez. He's been using an InBody since 2018 in his primary care practice alongside services like GLP-1 medications and weight loss programs, hormone replacement therapies, IV therapies, and body contouring. Dr. Chavez is a family physician who is passionate about in-depth preventative care. He's also the founder and medical director at Soulage Wellness and Aesthetics in Texas. Welcome, Dr. Chavez, and thank you for joining us. How are you today?
Hi, Bradley. Thank you. And thank you for the invitation. I'm delighted to be here and excited to have a good conversation around body composition. And hopefully we get more people to do this instead of relying in old-fashioned BMIs and weight on a scale.
Thank you for joining me. Let's have some fun. Let's go
Absolutely.
and talk a little bit about who you are. Tell me more about where you got your start in medicine.
Yeah, I was born and raised in Peru, South America, and my father was a physician, a surgeon, and he had trained in the U.S. Mayo Clinic and Bellevue Hospital, and went back to Peru and practiced medicine there. I was exposed to medicine early on, and probably the expectation of most was that I was going to be a physician. However, I had I like to play a lot with my hands and kind of fix things. So there was a brief period of time that crossed my mind to be a mechanical engineer. But then after getting exposed more in the hospital setting and clinic setting, I decided medicine was my career. I really kind of complemented both things, my passion and intrigue about fixing, and just kind of be able to deal with people and kind of their thoughts and their desires to be better and healthier. So that's how I got started. I went to medical school in Peru, and after I finished, I spent a little time teaching anatomy at my medical school, and then decided to pursue my specialty in the U.S. I came over. I had two brothers and a sister living already here, and in Texas, and I ended up in the family practice residency in Galveston, UTMB. I spent 3 years there. The last year I was a chief medical resident there, and shortly after that, I moved to Bastrop, Texas, kind of in the outskirts of Austin, and I've been there for the last 18 years now.
How did the transition go from working in a hospital to the practice that you have more now? Tell me a little bit about that.
It was interesting. Private practice is a little bit different. Obviously, we don't know much about private practice or learn about private practice in residency. It's just kind of that's the thing that we're supposed to do afterwards. We learn all that process of private practice as we go. Hospitals are rich in resources and specialists and all sorts of things, especially in a big teaching hospital. And when you become a family practitioner in a suburban or rural area, then you have to do a lot of things on your own. I was lucky enough that the last couple of years of my residency, I did some rotations in rural Texas, and was able to get exposed to the full scope of what a family practitioner is able to do, and kind of learn about the resources there. So that made the transition a lot easier. A lot more responsibility. You're on your own. You have to be lucky to have a good partner, a good doc next to you as you learn the ropes. But I think it's in everybody's DNA as a family practitioner to kind of just expect those challenge situations and learn.
So you went from the hospital into your own family practice, and then you now also offer medical aesthetic and weight loss services.
Yeah, so when I came to Bastrop, I joined a very well-known family practice, and the one to be my partner and since retired, he was very kind and very knowledgeable. He had been in practice in Texas for, by that time, close to 16, 20 years, and kind of I grew alongside, and eventually, like I say, we became partners, and then he retired. And in my young interest, I decided that I wanted to offer more things to patients, and one of those things was geared towards the use of technology, and technology led me to lasers, and that's kind of how the aesthetics part got started.
So what kind of patients do you see coming into your office today? What kind of needs do they typically present to you?
So for the first about 13 years of practice, I did traditional family practice, and I felt the challenges that probably most of my colleagues in the same field are feeling, which is, we're practicing a lot of reactive care. And I felt that there was a lot of left on the table on how to prevent disease. I love and I'm passionate about, helping people that are ill, and I still do that with equal passion, but I needed to find an avenue where I could just try to help those that are still healthy or haven't developed any significant problems to avoid them completely. And for that, the structure and the environment in which I was able to practice had to change. And that's kind of why, I incorporated the MDVIP model within my practice, which allowed me to create that preventive care built in for each one of my patients. And that allowed me more time, and time is crucial to develop those relationships. And with that, now I'm able to see a lot of people that are very interested in preventing disease. Like I said, still are able to practice in a much more thorough way in fixing those conditions that are pre-existing in some patients. But I also have the time, and I'm able to acquire the knowledge to help those that are interested in preventing it from the start. And so I get all kinds of patients. I get those challenging patients that have multiple problems that can't be addressed in the typical 5-10 minute visit, and that kind of help. But I also get a lot of patients that have decided to make improvements. And obviously, one of the big things, because it's kind of the number one challenge in this country, is weight. So a lot of people interested in losing weight. And then we start having the conversation about body composition, just because that number in the scale doesn't really mean much. And we know that, increased weight, increased adiposity, to call it the right term, carries, other risks for other developing other conditions, hormonal problems and cardiovascular problems, of course, and endocrine problems. So, we have deep conversations about that, identifying those risks and getting to the root cause of it and being able to correct them before it become a bigger issue for them.
Tell me a little bit more about MDVIP, because that seems to be the foundation where you came in to talk about the assessments, and what kind of treatment or care are you providing through that program?
Yeah, so MDVIP, contrary to what most people would guess, it stands for value in prevention, right? MD, obviously, for the physician part, but the VIP is value in prevention. So it is a core program that was founded over 20 years ago, and its whole foundation is around preventive care, and primarily trying to prevent cardiovascular illness, which has remained for decades, if not a century, the number one killer in this country. Even beyond the year that we had COVID, it was still the number one killer. So we do very in-depth assessments there using ancillary tools, which are labs and different modalities of testing. InBody being one of them, to be able to identify the risk factors that patients might have. Sometimes we uncover actually pre-existing disease that needs intervention more aggressively, but a lot of times is risk factors that were unknown to the patient, and we give them the tools to be able to correct those with the idea that we're going to prevent disease altogether. So the program bases this assessment in a two-part visit. They're about 1 hour assessments each. The first part of that visit, or the first visit, is to do the assessment medically, where we do the testing, the blood work. Um, we do EKGs, ankle brachial indices, pulmonary function test. We do a body composition test, and we also deploy a lot of wellness questionnaires, because we know that mental health plays a profound role into the outcomes of patients as well, and has a significant impact on disease itself. After we get all those results, primarily the blood work takes about a couple of weeks. We use Cleveland Heart Lab primarily to get our test run. Then we have an extensive meeting, an hour and a half, that we spend with the patient. It's me and the patient, and anybody that the patient wants to bring with, to discuss those results and identify the risks and elaborate a plan to correct them. And that's kind of where we introduce patients to kind of all these new results and new measures and everything. It's a very interesting and productive conversation.
It sounds like with all of that information, you really have a lot of information to tailor approach to the patient based upon all the assessment. Adding the aesthetic services after that, does that come as an add-on once you figure out what kind of needs that this person has and you're able to identify new ways that you can help them?
Well, that was a little bit of both. It also allowed us to broaden the reach that we have with certain wellness services. As you know, in the insurance world, a lot of it is just covering reactive care. So a lot of that preventive care is really just kind of left out for the patient to find it. And we want to provide that guidance. So there is, giving them resources for weight loss, not only from the standpoint of these novel medications, the GLP-1 medications that are out there, but also, structured weight loss programs. We've been very successful with Ideal Protein protocol. We've done that for almost 15 years now, with great success, and then complementing nutritional deficiencies with IV nutrition therapy and hormone balancing as well, that we are able to provide. And just to kind of just clarify, because there's a lot of talk about hormones, we like to do hormones in the people that actually need it. It's not just treating a number, it's treating the person. So we really focus on identifying the symptoms that could be attributed to that, and if that person does, have the characteristics, the clinical signs and symptoms, as well as the deficiencies noted, then that's kind of the people that we want to really help. But it was a way to broaden our reach into all those wellness aspects that can help also, prevent disease down the run. And then we complement it. Obviously, people start feeling better. They want to look better. So we do offer that aesthetic component of it. I think everybody's entitled to that. Some people, there's a big change just by not only feeling better, but looking at themselves better in the mirror. And that motivates them to kind of just continue to change. So it becomes a positive snowball effect.
Take me back to when you were choosing a body composition analyzer. How did you become interested in incorporating it into your practice? And was there, you mentioned earlier, being able to measure adipose tissue. Was there any other specific problems you were trying to solve as you were helping your patients be able to see their body?
Actually, it all came around the Ideal Protein protocol, right? So we had Ideal Protein allows you to lose a significant amount of weight fairly quickly. And the concern was that, what kind of weight are we losing? So patients saw the weight come off, and there was that concern. Are they going to gain it back? They're not going to gain it back. So got exposed to a couple of vendors that talked about body composition. Some were very, very basic. Other ones used kind of DEXA technology, which was, occupied a lot of space. And somebody along the lines started talking to us about InBody. So we took a closer look. I read about bioimpedance and how that the accuracy of that, and I was really interested, and we came to choosing a device I really wanted since I was already thinking about preventive cardiovascular care. You know, I was really interested into visceral fat, so that's kind of what really led me choosing the InBody I have now, the 570, and had for quite some time, because that allowed us to keep track of that, to set some very specific goals to the patient as well.
Was it easy to incorporate the InBody into your business and your programs?
Oh yes, really, people loved it. I think we are all, as humans, we like objectivity, right? We want something that we can grasp and follow a number. So, when people start not losing weight, and they look at the scale, they get frustrated, and or even worse, they were done with ideal protein and they kind of corrected their eating habits, and they started exercising more. They went to the gym, lifted weights. They started seeing that weight go up. So the big question mark is like, why? What's happening? I'm gaining all this weight. I lost it all through the program. What's going on? So just to give them reassurance that their percentage body fat or their body fat mass was still low and unchanged or even better. And the reason that their weight was up is because they had more muscle. And again, sometimes because, depending on how much muscle they put, a little bit more water retention with that. But, it was a healthy retention at that point. So knowing and showing them that was very helpful. So it was an easy incorporation. Everybody now that goes to us has been there with us a few times. That's all they want to do. They don't care about the scale itself. And we commonly tell patients is you can use every once in a while your scale at home as a reference, but your waist circumference is more reliable at home, and your InBody in the office. That's kind of really what we go by.
How has the customer service and support been for you from InBody?
It was been very good. I can't complain. It's a very easy machine, so it's not like we're doing with a complex laser. So we don't have to be, worried about constant training or things of that sort. When we started, we might have had some questions on why some variances, and what things can we do better? What's the best time of the day to weigh the person, and what precautions before weighing them? And we always got a quick answer. I think also reading the bulletins that the company puts out, it really helps us further understand the value of body composition and tips and tricks of that sort. I think that's it's a very low maintenance device. I think the most we've needed the help with is when there was that transition to the cloud-based, where we store all the client patient data on the cloud. And, that was they've been very helpful with that. And like I said, it's we don't need much from the company, but when we need it, the company has been there for us.
What's the culture like from the patient perspective about body composition when you introduce it to them? Is there ever any hesitation, or how do you overcome any type of challenges related to that?
Well, the vast majority is unexposed to it. They when they come the first time to me, all they're talking about is weight and BMI, right? And that's really where we start the conversation, to make them understand what's BMI, right? BMI is an index that's composed of weight and height. But it tells you nothing about how you're made. So, you commonly use the example. You look at Hulk, Lou Ferrigno, and their BMI is in their 40s, and do you consider that person obese? By no means. Probably their percentage body fat is less than 10%. That's why you can see every single muscle in every single vein. Right. But on the other hand, you could have somebody that you consider them skinny and their BMI to be at 24.9, which technically is, normal, non-obese person. And their percentage body fat is, 35%. Their muscle mass is very low. So technically, even though by unfortunately current medical definitions, you cannot call that person obese, but it does have an adiposity syndrome situation, and that's equally dangerous as somebody that's actually truly 35 BMI and truly, obese and excess percentage body fat. So I tell them is like we need to really, divert from that concept, and says that's why, and we start talking about disease processes and conditions, and one of the most probably undiagnosed situations, which is very risky, is metabolic syndrome. And one of the criteria of metabolic syndrome is waist circumference. Guess why they don't have BMI as one of the criteria? Because it's recognized that it's an inaccurate way that doesn't confer any risk. Now, indirectly with that waist circumference, what are we measuring? It's visceral fat, right? And so that just tells us that every single reliable prognostic risk measure doesn't take in consideration weight alone or BMI alone. Let's say they do mention that, but there's other, there are other measures that go with that to give validity. And the reason I don't think it's not broadly used, percentage body fat as a definition, is because not every physician office has a body composition analyzer of any sort that is reliable.
Can you take me through some memorable stories or experiences you've had with patients and them seeing their changes over time with the results on the InBody?
The most notable ones are those that say, "Oh, I can lose weight on my own. I know how to do this," and I enable them. Right? Great. If you can do this on your own and you know how to do it, do it. But before you start, I want you to step on your body and do a body composition analysis, because we're going to use that as a reference. And when I see you back and said, "Just give me a couple of months or give me 3 months and you'll see," and I said, when you come in 3 months, we'll just repeat this. And I know you've lost weight, so we're going to have a conversation. And I could tell you that 9 times out of 10, what really happens is, either they come at 3 months and we get them and do their body composition. And we see that, yes, they did lose weight, but they lost a tremendous amount of muscle, and they did lose some amount of fat. And or they come much sooner because they're frustrated, they can't lose it, and kind of we repeat the same test, and we see that there's been no change with the changes that they've done. But I think the most important part is when we illustrate people that yes, you can achieve weight loss. They come in all happy 3 months later thinking they've lost these 10-15 pounds, and then they realize that half of that weight is muscle. And they don't realize what losing muscle does to our metabolism. And then that's another opportunity to educate people, is that, the way our body regulates our burn, our caloric burn, which we all know as metabolism, but really the term is basal metabolic rate, is determined by our muscle mass. And if we lose muscle mass, we are resetting our metabolism down. And the danger of that is that if you go back to a balanced diet, so a non weight loss diet, you go to a normal diet, that normal diet is going to actually make you gain weight. And the sad thing about it is that you're going to gain that weight you lost. It was half muscle, half fat, and all fat. So at the end of the day, you're going to be in a worse situation than when you started. So it's very important to lose weight the right way in the first place. And, I do stress to patients that. And that really is why I emphasize patients when we introduce these medications, the GLP-1 medications, semaglutide, and now GLP-1 GIPs, tirzepatide, is that, we have to follow this very closely because they're very effective. They have many more benefits than just weight loss. And I'm a big proponent of their use, but they're just a tool, right? And if that tool is not used in conjunction with other tools and the right coaching, they can be very dangerous in the sense that they can set us to very big failures. And we hear those things in social media and the news is, I did this medication, lost all this weight, gained it all back. So I have several stories with that as well. Where patients, we've started on these medications, and their compromise with me is that they're going to lose, no or very little muscle in the process. And if they're consistently losing muscle at a rate that I don't consider that, acceptable, or is not acceptable for their health, then we discontinue the medication until they're mentally prepared to make the dietary changes to preserve that and the exercise that needs to come with that.
One of the things I hear you saying is that the InBody allows you the opportunity to engage your patients to get that baseline and then re-engage them down the road to help continue the conversation, whether they do it on their own or with yourself, and then even identify opportunities to adjust their treatment plan. Say if they're not, if they're losing their muscle mass, what kind of strategies do you deploy to help people build muscle or even maintain their muscle mass?
Well, if people are invested in exercising and they're going to incorporate at least a very basic program of 30 minutes a day, whether it's cardiovascular, a combination of cardiovascular and resistance. So I do encourage resistance for muscle buildup. That's the only one that really accomplishes that. The InBody gives me the muscle mass or the weight, and the muscle mass that I'm going to work to determine the macros that they're going to consume. So I really base my daily caloric consumption when they're designing a kind of very basic dietary plan based on their weight. And typically we use more of the ideal weight based on the muscle mass and the ideal proportions that that person should have, and we calculate the amount of protein that they should consume. And typically I part very basically from 40% protein, 20% fat, 40% macros, carbs, in somebody that doesn't have diabetes or kidney disease, and somebody that might have some high blood pressure or diabetes, or high blood pressure or some obesity, and just is invested in trying to kind of build the muscle, lose the fat kind of situation. So the InBody really gives me that tool to make those calculations, and then to show them, like, look, with this amount of calorie, with this distribution in macros, you're consuming 1,800 calories, and your body is already burning 1,700 based on what you have. So really, the next step is we need to create caloric deficit. And so you need to burn this extra amount of calories to put yourself in a caloric deficit. If you do that, you're not going to lose muscle, and you're going to burn the fat. And then we further have the conversations about, causing some sort of muscle inflammation. And with the adequate amount of protein, they can go and continue to build that muscle as well, and we can track the progress of that. So it's very interesting. It sounds like a lot of labor-intensive work, but there are some tools and there are apps, and in this world, we always can use technology to our advantage. It's sometimes can be really frustrating, but sometimes can make our life fairly easy. And we can use those tools just to kind of guide them through the complex, what could be a complex journey of diet and so forth. Now, as more medical issues that they have, there's always kind of the opportunity to bring somebody that, has, go in depth to study nutrition and all that. And they always, love to have a body composition with that, because it really also guides their recommendations and their progress of the recommendations. And then when you involve a trainer, an endurance trainer, or a gym trainer, they love to have the InBody because they know which muscle groups to target or what parts of the body and where to work more intensely and where is the greatest opportunity for that. So it's a great tool.
Speaking of technology that makes our jobs easier, there's a company that is integrated with the InBody to pull the body composition data into a meal tracking software where your patients get an app where they can log all the food that they've eaten. And on the back end, you get a dashboard that shows where you can build them a customized meal plan for the amount of macros and micros that you want them to get. And then you can see every day that they enter it, how well they've aligned with it. And then the body composition data is tracked alongside of the food that they've logged. And it actually uses the amount of muscle and fat and the water ratios to continue to help edit the macro plan. and help them achieve their goal. And it's been a great solution that a lot of clinicians have and a lot of physicians are able to scale to 100 patients on this service. And there's a lot of kind of intuitive coaching also built into rewarding and helping move the patient along to altering their meal plans too. So I recorded an episode on that. I'll send it over to you so you can check it out, and might be something
Yeah,
that you could
absolutely.
integrate in as well.
Yeah, I would love that. I would love really that. Anything that gives us that inside information and perspective on the patients is great. Today I learned about a couple of portals that these CGMs, continuous glucose monitoring. You can, if the patient inputs the code for the physician, you can have all your patients, tracking their glucose readings and things like that. I think. When there is a good relationship with the physician and you're going to use that data meaningfully, it's amazing. It's amazing. So that just really facilitates, the care that we can provide for patients and the guidance. It makes the conversations much easier.
Can you tell me more about the changes that you see in patients that are starting medical weight loss medications for diabetes, like the GIPs or GLP-1s?
There is weight loss, but there's a little bit more than desired muscle mass loss. And the reason I tell them patients will, they have to be careful about that is because the main way these medications work is for weight loss is twofold. They, make you less hungry, so it's a central to the brain, and then they slow down the movement of food through the gut, specifically the stomach, so the food sits there longer, so you feel fuller, which sends a signal to your brain that you're full. And that's the main way the basis at the end is decreased intake, right? So you're eating less because you're less hungry by two different mechanisms. What happens if I don't give you any guidance and I put a plate in front of you and I tell you you can only eat half of that, and the plate's divided in vegetables, your favorite starch, and either potatoes or rice, which you love, or and by starches I mean, let's say you put beans or something like that. So, but you put vegetables and protein there in a little third of that, and then just other 2/3 is going to be some sort of starch mix. So, if I don't give you any guidance and all of a sudden I put that plate and it says you can only eat half of that plate, you're going to eat probably the half that you like. And usually it's going to be that fat and carbohydrate portion. And you're going to forget about the vegetable and protein side because you're just saying, it's like, I can only eat half of that. So I'm going to eat the stuff I like. All right. And if you don't coach people, yes, they're going to lose weight. All of a sudden, on a plate that was, I don't know, 1,000 calories, now you're just going to eat 500 of it. Yeah, if you're eating half the calories, guess what? You're going to lose weight. But if you're not eating any protein or hardly any, and all of that you're eating is fat and starches, most of your weight loss is going to come from muscle because you're not feeding your muscle to be maintained. And that's why I say these medications are a tool. And a tool is only as good as the one that's using it. And the ones that are using it, or and they're is as the physicians or the providers. Us as providers have a big responsibility of following on these patients very closely. A lot of times we worry about the potential side effects and so forth, and we're good about that. We tell them if you have abdominal pain and you're throwing up, and I need to know about it. So we focus on that, which is great. I'm saying, let's not forget about that. That can be potentially life-threatening, so we really need to focus on that. But we fail to monitor the endpoint and how we're achieving the endpoint. A lot of times they get prescribed these things and they don't see a physician 3 months later, and they come back, they lost the weight, and because the physician is not able, or the provider is not able to monitor their body composition, they think they're doing great. They lost the weight. They obviously look thinner. But if they were just to see what's happening in their body and it's the wrong kind of weight loss, that I think the action would be very different. So I bring them usually every 6 weeks. And at the beginning, I might get a little lenient towards, more in depth than we are, and I'll put them in every 2 months. But at the very least, every 6 weeks. Sooner, if I perceive there's going to be a challenge. Sooner, if I see that in the first repeat body composition, they've had too much muscle loss. And we always have the conversation about muscle. And I always tell them, you don't want to lose muscle because of, and I tell them about their metabolism and how they will regain their weight and things of that sort. And I also tell them it's in your best interest to build muscle and to eat your protein first and your vegetables to avoid the constipation. But it's in your interest to build muscle because the more muscle you build, the more fat you're going to burn. So, you're going to improve your body composition much faster if you do it this way and use the opportunity that the GLP-1 or the GLP-1 GIP combination is, making you not hungry, just to rationalize over what you eat and retrain your brain on, what you should be eating and not eating. And by no means nobody's going to be perfect. Even if you're off these medications, you will slip here and there. It's not a vaccine against obesity. It's like anything else. We're addicted to certain types of meals, and just like people that quit smoking for years and relapse and they quit again. It's kind of the same thing. It's trial and error. We have to keep trying. But yeah, no, it is challenging. I think we have the responsibility to do things right. I see a lot of providers that refer out just because they realize they don't have the tools to monitor it, not because they're not comfortable, they lack knowledge, but they recognize that it needs a special surveillance. It cannot just be handed out like it was nothing, and it's beyond the potential medical complications that can exist. Is everything else that's tied to it.
What about a hormone replacement therapy? What kind of results do you typically see on the InBody related to hormone replacement therapy?
A lot of times, the reason that people are deficient in hormones is because their body composition is totally off. They have a big amount of adipose tissue, which is sequestering their hormones, and that just has them a low level of hormone circulating in the body. So as they will lose the weight, those hormones tend to increase. But primarily testosterone, because both in men and women we use testosterone quite a bit. And again, as a tool, we have the recommendations that go with that. We tell them to, go to the gym, use the increased energy that you're going to experience because of higher testosterone levels, and use that motivation and that energy to go and engage yourself in some sort of resistance training program, even if it's a little bit at a time. Even if you did zero exercise and start the first few weeks at doing 5 pounds and then 10 pounds and then 20 pounds. It's a gradual progress, because that's going to make your treatment more effective. And it's all about that. It's just making the treatment more effective. The truth is, people sometimes come to me or us, if it's in the wellness side, and said, oh, my testosterone's low, I want testosterone, right? And it's just like, okay, why do you want testosterone? So we have usually a symptom checklist, and but we would like them to tell us why, and then we have the conversation of what they need to do in order to make this treatment better. It's not, there's nothing out there that I know of that is just take this one thing and it'll fix everything. We have to put a little bit of effort on our end to make and to have the optimal results. It's a growth in muscle mass. We see that all the time with testosterone hormone replacement therapy and the body composition. And there's a little bit of water retention, right? Obviously, the muscle engorges. There's a little bit of water retention, so we are able to demonstrate that to the patients that say, "Oh, my ring's a little bit, tighter," or "I have the indentation of my socks," and well, that comes with that. It's transient usually, and with kind of diet and exercise, and it will get better.
A lot of people ask how often they should test on the InBody. And one of my first responses is typically it should be equal to the amount of effort that you're putting in to make changes. So if you're putting more effort in, then it might make sense to check a little bit more frequently. Versus if you're not,
Ex-
I'd say at least annually we get a test done so we can see some trending values, but it helps to kind of put a scale to how frequently somebody should test with what other kinds of modalities of therapy we're doing or even effort that somebody's putting in to try to change the body composition.
Exactly. And you said it right. It's just all about the effort. If you're going to the gym every day and you're working hard and you really want to see the motivation, then you could test in 4 weeks, all right? And you can see a change there. But if you're taking it slow, the only thing you're doing is dietary changes, and you're really not picked up on the exercise. Well, maybe we do it in 3 months. You want to be some results, so we don't want to discourage you. So if I do it too soon in those settings, that person will get discouraged because there's not that other component that will make the change happen faster. So we have to give it a little bit of time. No, it's a tool of encouragement, not of punishment. So we have to use the right time frame to encourage our patients. Otherwise, you create frustration and they'll give up, and we don't want that. We want them to be positive and ongoing change.
How do IV therapies play into your business model?
A lot of times is symptom driven, lifestyle driven, and desired outcomes that they're looking for, and we do see improvements on that side quite a bit, um, and it's a complement to everything else that we do. We tend to do a lot to our bodies that deplete ourselves, and surprisingly enough, the nutrient and element and mineral content in foods has dropped dramatically over 50 years, because of the quality of the soil. And even if you had a garden at the back of your house, the soil everywhere is changing because the water is changing, the water content. So we have some control, but not all the control. And still with that, the food quality is not what it used to be, several decades back. So we are going to be deficient in several things because of that. So it's our job to investigate, not indiscriminately recommend, because we don't want to contribute to the burden of the amount of things that people take or do. But we identify the biggest deficiencies and replace them, and then knowing what to replace it with. A lot of people don't realize that the lack of regulation there is on supplements in the US is they just have to meet a certain very poor threshold to be able to be sold. And just telling somebody go and buy whatever you can from Walmart or HEB or Walgreens shelf, a lot of people choose the wrong things. I'm not saying that everything there is poor quality, but there's a lot of stuff out there that doesn't have the elements and ingredients that it should have. And that also creates, it's like, oh, I took that and it didn't work. Well, what brand did you take? Did it really have the amount that was supposed to have? Did you check and see if it was a company that had third party testing to know that those elements were there? So it's not necessarily that formula or the name of that supplement didn't work for you. It's just that you took the wrong supplement brand, right? And that sometimes generates controversy, but I am a firm believer that a lot of people are taking supplements that don't have what they're supposed to have, and that's why they don't see the results that they're looking for.
What about body contouring services related to your programs and the results on the InBody?
It comes of a later phase, a lot more to as a reward. People reward themselves with those services or those stubborn areas that they're not able to lose. Body fat. Typically, it's people that work hard at it. They really have invested time and effort in changing their diet, or they've done ideal protein, and they've been on GLP-1 weight loss, and they reach that point that really these parts that really annoy them, and they do that. So it comes a reward. when we do it outside of that, we really do it to monitor results, right? So people will come in and they're, just leading their usual normal life, and they want just to tweak that. So we get a body composition before, and typically the process of it's a series of treatments. It can do 3 to 6 treatments depending on the device that you're using and the technology you're using. And it typically takes a few more months to really see the results. So there's the visual aspect of it, where we take pictures, measurements as well, but there's also the body composition part. And we use that also to those patients that say, "Oh, I didn't see the results," or actually, it got worse. And typically those that didn't see the results or it got worse is because their body composition has dramatically changed. And I say dramatically from the standpoint of the finesse that we're looking, right? There was actually an increase in percentage body fat, and either no change in muscle or decrease in muscle. So yes, obviously you're not going to get the results you want if you're using a energy-based device to contour your body, and exaggerating, you're going out and eating pizza every weekend, and and fast food during the week. Don't expect results under those circumstances. If anything, it probably prevented from getting worse, but you're not going to get better. So you're not going to get that poster result if you do that. Those poster results are usually people that are working really hard at it, to just enhance it further with the technology. So it keeps people honest with the body composition. So we that's another area that we use it quite a bit.
What kind of advice would you give to a doctor or a clinic looking to integrate body composition into their practice? Anything that, as you look back on from where you're at today to when you started, that was important to you to think about alongside of that?
Well, talking to somebody that uses it in every single dimension of his practice, I think it's a necessary tool, a useful tool. If what you're really invested on is giving the best advice and counseling to your patients and information as well. I think body composition promotes change in people, just because you empower them and by giving them knowledge about their bodies. It takes the frustration away from the scale, the punishment away from the BMI. It gives them, more insight of all those things, and I think you are more likely to generate change because of it. It's an investment. We know that it's not probably cheap like a regular scale that you could get for medical offices, and the more sophisticated scales that you get for medical offices that have rails probably are more expensive, but still this comes a little bit at a higher price. But then again, it's what you want to accomplish with your patients, and if you can do it and you really have that mentality and philosophy, you need to incorporate body composition into your vital signs to be able to provide the best information, guidance, and ultimately get the best results from the treatments that you provide to your patient.
Well, Dr. Chavez, this has been fantastic. Thank you for sharing so much of your wisdom. If somebody wanted to get in touch with you after listening to this, what's the best way for somebody to reach out to you?
Feel free. My office is direct access to a live person. So our number is 512-985-6962. You can reach us through our website. It's www.drpompeochavez.com, drpompeyoChavez.com. And you can submit any questions you have through that means. And like I said, I'm there to help anybody that gets motivated, professionals, healthcare providers, or anybody out there that wants further information how to optimize their health. I'm more than happy and available to be there for you.
Fantastic. Thank you. I appreciate you joining me today, and we'll look forward to more great conversations to go. And if you're already an InBody customer, we appreciate your business and would love to hear from you about how we can best serve you. Let us know what kind of topics you'd like us to continue to discuss to help you optimize your implementation of body composition. And if you're ready to get an InBody, we're ready to help you grow your business. You can visit InBodyUSA.com for special offers. Just mention that you heard about it through this podcast, and a member of our team will follow up to help you understand our solution. Dr. Chavez, we appreciate you. Have a great day.
Thank you, Bradley. Thank you for the opportunity to share some knowledge with you guys.